And good morning, everyone. I'm Ryan Mackman, and I'm a business consultant with Salient Healthcare. I'm really excited to present here at NAACOS Live's Fall 2020 conference, and I really hope you'll both enjoy and find a lot of value about what we're talking about today. Presenting with me this morning, we have Maria Nicole, and she is a senior business consultant and part of our team at Salient. And we're also presenting on behalf of two ACO executives. Dan Bailey, the Vice President of Payer Contracting and Finance for ProHealth Solutions ACO, which is a next-gen ACO just outside of Milwaukee, Wisconsin. He was unable to attend, but was integral in helping us put this presentation together. And we're also presenting on behalf of Lacey Waddles, who is the Population Health Informatics Analyst for the Rocky Mountain Accountable Health Network over in Billings, Montana. She, too, was a valuable resource in putting this together. Now, managing performance across payers, it was put together because we know that as organizations take on more value-based contracts, we understand how difficult it is to manage each of those contractual and data variances. The Salient Healthcare team has been successful in integrating all of that data into our multi-payer solution. And today we want to share with you how we've gone about doing that. Both Dan and Lacey have engaged in multi-payer contracts, and they've successfully navigated many of the challenges that most organizations face. So Maria and I are going to go ahead and set the stage, and then we'll present both Dan and Lacey's use cases in an interview format where I'm going to ask the questions, and then Maria is going to answer on each ACO's behalf. Since 2012, there's been a lot of organizations that have embarked on their very first value-based contract. And in a lot of cases, they've learned a lot along the way. At this stage, many organizations have either added or are considering adding other contracts as they gain more experience in value-based care. The challenge, however, is that when you have so many contracts, each with its own rules, regulations, and nuances, then you end up having to account for so many variances, and scalability becomes a real problem. You also have different data sources depending on whether your contract is with Medicare, Medicare Advantage, Medicaid, commercial insurance. You're adding more data complexity, and that also means it's a lot harder to monitor performance. Now, in talking about data complexity, or variance for that matter, I'm going to go ahead and break this apart into smaller chunks and discuss where data variances are likely to occur. So first, attribution logic is a big one. You've got either prospective, and you have prospective with retrospective reconciliation. Now, regardless of which one you choose, managing that data can be really difficult when you've got several contracts, all of which might follow different attribution methodologies. Second, you've got your risk score logic. Now, some contracts use CMS's hierarchical condition category, and other contracts might use the Johns Hopkins model or the diagnostic cost grouper. If you can't easily view that information in one place, then at some point, you're stuck downloading all that data onto multiple Excel spreadsheets, and then you're trying to make sense of all that data. It's like trying to measure something in both maybe the metric system and the American Standard System at the same time. It can get a little chaotic. Third, you've got quality metrics. Now, depending on your contract and your population, your quality metrics can be very different, right? Quality metrics for women and for men aren't the same to begin with. Then you factor in different ages and different contracts, and you can see how quickly everything gets really complicated. Timing is its own challenge. First, you've got to deal with different attribution logic and different risk score logic. Then you combine that with different quality metrics. And then all that information is going to trickle in at different times, depending on the payer. So it's not improbable to have more than 12 downloads in a given month. Moving on to general data fields. Unfortunately, not all data comes in the exact same way. You have to design templates to fill in a lot of basic data fields so that you can then do proper calculations. And then without that, you don't even have a complete data set. And finally, the sheer amount of data available is really variable. So in both Rocky Mountain and ProHealth Solutions cases, they also look at their Medicare Advantage populations. Well, if you're going to go and get an apples to apples comparison of MA against MSSP, then you need to have the same data and the same amount of data coming in. But unfortunately, most Medicare Advantage payers don't provide information in the same format that CMS provides to its Medicare beneficiaries. And that means that someone has to go back and fill in all of those gaps. All right. Now that we've looked at the challenges with the different data variances, I'm going to briefly cover the data systems themselves. If you think about your typical healthcare organization, you might be likely to have anywhere from 1 to 3 EMRs. And then due to mass consolidations and acquisitions, you might have larger healthcare systems that have 8 or 9 EMRs. And in each case, there's an individual process to access that data in each EMR. Then you've got different data systems, just different systems that are required to access each payer's data. And so, for instance, you can download CMS's data directly through their portal. But if you have multiple MA contracts on top of that, then you've just added more portals that you need to regularly access so that way you can gather all your data. And finally, some data sources are only accessible through other data systems. As an example of that, you have your health information exchanges, and those are different in every state. And that's just the beginning. I'm actually going to dive into a lot of the available data sources over the next couple of slides. So this slide here, you're going to see are 11 of the CMS data sources that Salient regularly accesses and brings into the system. I could read them off, but these slides are all downloadable at the end of the presentation, and I want to try to leave some more time for the use cases. Now on this next slide, we have other data sources, including some from your multi-payer contracts. There's the HIE I just mentioned. And again, remember, there are different access points to all of these. So streamlined is probably the last word that I would use to describe any of this. Okay, we've gone through a few layers of the data itself, its sources. Now we have to look at the individual contracts to complete the puzzle. Each contract is slightly different, or in some cases, significantly different. As I mentioned before, you may have Medicare, Medicare Advantage, commercial, you might have Medicaid, and each of these contracts is going to make you adhere to different quality metrics. They're going to have different attribution logic, different risk score logic. Additionally, they might measure your success in different terms. So in some, you might have a minimum savings rate and a minimum loss rate, while others, they don't have that stipulation at all. And then with network management, some contracts require you to have preferred providers and some don't. So once you have all this data, now you've got to manage each population by the rules and regulations of its individual contract. At this point, I'm sure you're thinking this is way more complicated than it should be. So how do we simplify everything? You need a single solution that can aggregate all of that data from all of the different sources and then normalize it so you get an accurate depiction of your different populations, no matter where you're located and no matter what contracts you have. As you can see, that's not easy to do. And at this point, there's very few solutions that are able to pull this off both timely and successfully. And that's what Salient does. So what I'm going to do now is hand this off to Maria, and she's going to talk about how we're able to get that done. Maria?
Thanks, Ryan. So your organization will receive numerous files, typically throughout the month, and it's easy to get confused if all that data is not centrally located. Salient manages and maintains the data in one location, and we run timely, continuous data loads for our clients. Salient uses the templating layer for which the Medicare ACO data is the gold standard. Medicare provides this data in a standardized fashion on a monthly basis. Commercial payers only provide about 70 to 90% of the same data, and that includes some additional fields. We identify the overlapping fields and then use them in the same fashion. Next, we identify any missing data fields in the overall template. In this step, we may identify if there are other fields that can bridge this gap, or if that requires developing proprietary logic to accomplish that goal. Finally, we add in new data fields. The new payer becomes part of the overall schema, and that template can now be used for future clients. The template layer provides a systematic method of displaying the data in an apples to apples fashion. So there's certainly many advantages that our clients derive as a result of the Salient process. First, all of the data is housed in a single location, which means that there's no need to log into disparate systems or even spreadsheets. Second, it's very easy to compare performance across payers. For example, You can identify in a single scorecard how your organization is performing across all of the key performance indicators across all contracts in order to identify areas of opportunity. And third, many times our clients will receive static reports from various payers. This allows you to validate that information. Given our expertise in the industry, we're able to add a new payer within 8 to 10 weeks. And with payers that we're already familiar with, that turnaround time drops to just 6 weeks. The Medicare ACO data can be added to the solution in just under 2 weeks. All right, so now let's take a look at the KPIs that we recommend value-based organizations monitor across all of their contracts. There are 5 main categories that have to be satisfied for value-based organizations to finish with a spend that's below their benchmark, exceed the minimum savings rate, and hopefully achieve shared savings. And those categories are finance, risk, attribution, quality, and utilization. So for finance, one of the key metrics to track is the spend PMPY versus your benchmark. It will tell you whether you're on track to achieve shared savings. With regard to risk, it's always important to keep an eye on your population's risk score, both at the organization level and at the practice and provider level. Appropriate coding leads to a more accurate benchmark, and that enables you to anticipate the actual cost of care and the type of care that your patient population requires. This is the only way that payers know how sick your patients are and gives you credit for all the hard work that you're doing. So now we move on to attribution. We have 2 recommended attribution metrics, the percent continuously attributed and the percent of beneficiaries seen per quarter for primary care services. Based on our experience, those beneficiaries that have continuous assignment typically have a much lower spend. This is likely because they're getting the right care at the right time. Working our way over to quality, we recommend that value-based organizations monitor their annual wellness visit completion rate. This KPI literally impacts all of the other 5 categories. Your organization ultimately benefits as every single quality metric improves. AWVs reimburse at a higher rate than the E&M visit, and they help to develop a better patient-physician relationship. So this brings us into the utilization category.
Maria, you're back. Your audio cut out.
First, we're going to look at the TCM percent completion, since TCMs can significantly impact unnecessary readmissions. We also look at the visits per 1,000 for acute and post-acute care, and the 30, 90, and 180-day readmissions. This gives you a complete look at all of the KPIs that are available in the Salient Healthcare dashboards. All right, so depending on your contract, it may be helpful to implement initiatives around network management or working with your assignable populations. In network management, organizations may want to work with preferred providers and create preferred provider networks by identifying specialists that are high value. Your organization will want to track whether patients are truly seeing preferred providers or whether out-of-network providers are being utilized. If your organization is engaged in multiple value-based contracts, Salient is able to show your in and out of network provider designation that is specific to the payers. Many value-based organizations will receive assignable patients, not just those that are attributed. The assignable population may be helpful in growing your attribution and size of your organization. Salient has developed proprietary logic that's going to help you identify how likely that beneficiary is to become attributed to you. So now we're going to look at the Salient tech stack that allows us to bring in all the disparate data sources. I'm going to try to simplify this as best as I can. What you're going to see here is that we bring in claims data, the NPES registry, clinical data, and different payers, which are all part of the data ingestion phase. Again, we can bring in as many as you want, but for the sake of this slide, we only use the Medicare Advantage as a placeholder and as our example. Remember, this data comes in via diverse formats and at different times. Then Salient validates the data for accuracy and quality so that any data conflicts are eliminated, and then goes through the extract, transfer, and load process. And then there's a staging database where Salient provides all of the data enrichments. That's the templating and normalizing phase. And during this time, Salient takes the data from the database, organizes it using the Medicare ACO data as the gold standard. And after that, we identify those missing data fields that I'd mentioned. And then once the template is complete, that's where the last ETL process is, where that information then gets housed in the Salient data mart. It becomes the lifeblood of both SIM and dashboards, the two different interfaces. It takes a lot of work on the part of our tech team to make this happen, and just imagine trying to do this all by yourself. Salient keeps on top of what data is being fed in and when, and then make sure it's available for you in an easy to read format. I'm now going to hand it back off to Ryan so he can demonstrate how all of these features work together in the Salient solution.
All right, thank you, Maria. The Salient Healthcare platform is predicated on continuous process improvement. So since I'm kind of a CPI junkie, I wanted to show this quick diagram showing what we're looking to accomplish. Now, I know we're limited on time. So with that, I'm actually going to change my screen over now. So you should be able to see in just a moment the Salient Healthcare dashboards. Maria, are we on screen? Yes. Okay, excellent. Now, the purpose of this is to show how Salient can help manage all these data sources, because talking about this isn't the same as actually showing you. And I want to preface this portion of the webinar by saying that this data is all from a demo set. There's absolutely no PHI being revealed at any time. Now, this page that you're looking at is literally the first page that all of our clients see when logging into the dashboards. This is what we call our landing page. And you can see along the top here, we have MSSP data, and then we have two different Medicare Advantage contracts. In this case, we used Humana and United Healthcare as our example, but we can bring in any payer that you choose. It could be MA, it could be commercial, it could be Medicaid, it could be Medicare. Now, Maria mentioned the different KPIs earlier, and you can see on the left there, you have your benchmark, you have your spend to ensure that you're under the benchmark. You also have your population's risk score, and you have your annual wellness visit percentage, which we mentioned earlier was a proxy for quality. Now, you're going to see those red and green highlights. Those are directive, and they're designed to tell you if you're trending in a desired or an undesired direction. So in this case, you're not seeing any yellow highlights, but if there were, then that would represent little or no change. You also have some MA trends down there in the bottom right-hand corner, and that's giving you the MA population, their net revenue over time. Now, again, limited on time, so I'm going to go ahead, and we would normally use the navigation bars here on those different KPIs, and I'm going to flip over here to the ACO scorecard. And what you're going to see here, that ACO scorecard's under the financial category, and you're going to see 8 widgets that present all the KPIs as percent changes. And that's so you can see how your organization is trending between 2 different time frames. So it's basically an organizational report card. In this case, you also have the ability to evaluate your MSSP and your MA populations against each other for a more accurate comparison. You see the ACO, the United Healthcare, and the Humana as the examples there. Now, you can see how we're bringing in multiple data sets, and you're able to get a really good look at what's going on across your organization, across your practices, across your providers, your different populations. And we can do that because I can actually change what I'm looking at here, and I can look at a list of, oh, looks like I got logged out. So if anybody's having any internet issues, I'm totally understand. So we'll log back in real quick, and you should be able to see I can change the, here we go, right back to where I was. Perfect. And once that loads up, I can change to show my providers in my accountable care organization, and I can expand this. And then I can change to numbers view. And that's going to give me a more tabular view of what's actually going on. I also have the capability, if I wanted to, I'm going to restore this down, and we'll bring up a filter panel, and you have the ability to look at your practices, your providers, and you can look at everybody specifically by payer. So you have the ability to control all of that, and we can bring in all of those different payers and do those analyses. Okay. At this point, I think you have seen enough of Maria and I talking about what we do. And what I'll do now is we'll get into our use cases because we have limited time. So our first set of questions comes sent to Dan Bailey, the VP of Payer Contracting and Finance for ProHealth Solutions ACO. We asked him to talk about how he actually uses these data visualizations and cross-cutting metrics so that he can ensure his patients receive consistent treatment and care outside of Milwaukee. I'll read each question. Maria's going to give his answers, and we'll start out with the first question, which is ProHealth Solutions background. Maria?
All right. So Dan's response was, ProHealth Solutions is located in Waukesha, Wisconsin. It was formed in 2010 as a joint venture between ProHealthcare and a community-based healthcare organization and the Waukesha Elmbrook Healthcare, a physician-led IPA. It was originally formed in order to participate in various value-based contracts with commercial and governmental payers. PHS started in the Medicare Shared Savings Program, MSSP, in July of 2012 and moved to the next generation ACO model in 2017. PHS manages over 96,000 attributed lives in various value-based contracts, including 16,000 in the next-gen ACO model. PHS has earned shared savings in each year of the next-gen model.
And now, why did PHS decide to engage in multiple contracts?
PHS has engaged with Salient Healthcare for several years. We started with data from our next-gen MSSP models and found the information very valuable in identifying key drivers and trends in performance. It has allowed us to identify focus areas for our operational teams to drive continued performance improvements. After finding value in the tool for CMS lives, we decided to move forward with the addition of 2 other Medicare Advantage payers. Since payers typically have disparate data sets, Salient has allowed us to bring in the data into a consistent data format. The additional payer data now allows us to compare and contrast trends across multiple payers and a large number of lives.
And now the next question is, what initiatives are you currently working on?
We've been able to use the Salient Interactive Miner to create proprietary population health dashboards. This dashboard allows us to report and analyze performance for 15 key financial, operational, utilization, and leakage metrics, both in an all-payer and specific payer view. We're reviewing the Salient Dashboards tool to better identify potential areas of opportunity for our operational teams in risk coding and managing high-cost cases, just to name a few.
And how has the Salient solution made it easier for you to manage that performance?
With the addition of the additional payers, we now have a view into over 90% of our at-risk Medicare Advantage lives. Previous to the implementation of Salient, we were literally flying blind, mainly relying on high-level summary performance data provided by CMS and our contracted payers. The tool now allows us to drill down and identify the key drivers of performance and potential areas of opportunity. Without this tool, we would not have felt comfortable moving from shared savings to shared or full risk arrangements. This has then in turn allowed us to increase financial returns on our contracts.
And again, special thank you to Dan Bailey for providing those answers to us. We really would have loved to have him on this call with us, but the timing just didn't work out. All right, now I'm going to change to my second use case, and this is with Rocky Mountain Accountable Health Network in Billings, Montana. Lacey Waddles was also unable to be here in person, so just like we did with Dan, we sent her a series of questions, and she responded in accordance. So I'm going to read out what we asked, and Maria is going to provide Lacey's responses, starting with Rocky Mountain's background.
Rocky Mountain has been in existence since 2013. It was formed specifically to contract with CMS and participate in the MSSP program. Rocky Mountain was without a data solution for the first several years of the MSSP program. As the ACO matured, the need for a data solution became more evident. Salient solution met our needs for the MSSP. It was easy to implement and it provided us with the level of data we needed in order to understand our costs. The MSSP currently operates in Yellowstone County in Montana. It has approximately 9,000 attributed lives. We had a savings rate of 2% for the year ending in 2019, not enough to get shared savings. And we had an overall quality score of 95.69.
Excellent. Now, why did Rocky Mountain decide to engage in multiple contracts?
At the same time we started our MSSP journey, we also started a journey with Humana for a Medicare Advantage plan that includes shared savings opportunities and quarterly quality bonus potential. Both the MSSP and the MA plans are upside risk only. The MA plan has grown from 500 covered lives to 5,000 covered lives. As the number of lives grew, it became clear that we needed a better data solution than what was offered by Humana. Since the success of the MSSP and MA plans are closely aligned, it was easy for us to look to Salient for our data solution for both.
Now, what initiatives are you currently working on?
Our main initiatives include attribution, annual wellness visits, and risk adjustment. We use Salient to monitor the cost of care trends over time. It is very useful for analyzing leakage. Post-acute care has been important to both of these products, and the Salient tool has helped us understand the difference of cost for a traditional skilled nursing facility versus a skilled nursing bed in a critical access hospital. We're able to provide reports on the cost of care to participating providers. Having both the MSSP and the MA plans in the Salient tool gives us the ability to compare and contrast the cost of care for these two programs and helps us ask why should the cost of care differ when the reimbursement is similar.
And finally, how's the Salient solution made it easier for Rocky Mountain to manage their performance?
Having all the data in one tool makes it easy to monitor and manage performance. Consistency in reporting is helpful and useful.
Again, special thank you to Lacey Waddles for providing those answers for us. We'd also have loved to have her on this call, but timing just was a factor. So with that, we've completed our 2 use cases, and I know some questions have already come in, and it's your turn to ask those questions. So we're going to open the floor for Q&A. I have seen a couple come in already. Let me expand my window here. It looks like the first question is, the Medicaid population is different from the Medicare population. What kind of experience does Salient have with Medicaid data? Well, to be honest, we are working closely with New York State. We started out in healthcare doing Medicaid. We started out 15 years ago working with their DSRIP program, and that's actually how we got into value-based care. So Medicaid was our specialty long before we got into the MSSP program. And the next question is, are you able to integrate with other data vendors that we're currently using? And the answer to that is sure. As long as those data vendors are willing to work with us, we can take in any data that you want, no matter who it's from or no matter where it's from. Okay. This is a question for Maria. It says, what if I want to do an analysis that is not part of the pre-built dashboards?
Salient actually has 2 interfaces, the Salient Healthcare Dashboards, which Ryan went through today, and also Salient Interactive Miner, which allows the user to be able to do ad hoc analyses without any coding experience. It's all point and click, so your data analyst can certainly look at it and dig into it, and all of the payers are in a single solution to complete those ad hoc analyses. So I also wanted to point out that we are doing a full demo that includes SIM tomorrow at 10:30, just before the virtual session starts, if you would like to see more.
And also someone said, bringing in all that claims data from different payers is great, but don't you need EMR data to complete the picture? So that's a good question. And that's up to each individual ACO or CIN, but the true answer is not really. When you're implementing initiatives to drive change, it's more often the trends that you want to look at. Trends are generally going to look back at where you were so that you can get in front of where you're headed. For example, when you're looking at SNF data, your EMR data is not going to change drastically in a short period of time. and your trend is still going to hold. The idea would be to look at actual SNFs themselves and then look at how they're caring for your patients, whether or not they're keeping the beneficiaries too long, whether they're providing appropriate care, et cetera. And you don't always need EMR data for that. But when you bring in EMR data, it is more real time. However, you're also looking at unadjudicated claims, which means that the information you're looking at has the propensity to change after it's been processed. So that's something to take into consideration. Maria, I think this one is towards you. What's the most common performance gap that you identify and can help us address?
So typically what we do is we will bring in your data. We do a 45-day risk-free trial, and the consultants, myself and Ryan, Stephanie, and Amy, will do an assessment for the organization to identify the top 3 areas of opportunity that are specific to your organization. However, the performance management solution allows us to specifically look at those. And what I've seen is a lot of organizations want to start out with their annual wellness visits and making sure you're getting patients in at the right time. And we're also looking at risk scoring and attribution. So typically organizations start there, and then from there we expand out to other initiatives, which might include hospital utilization, ER utilization, and other initiatives in post-acute care. That's just a few that we have implemented with our clients. And that information is, again, housed within our performance management solution.
And it looks like that is the last question that has come in, and we're up against time anyway, so that worked out perfectly. So thank you again. I want to thank everybody for attending this presentation by Salient Healthcare, by ProHealth Solutions ACO, and Rocky Mountain Accountable Health Network. We look forward to continuing to help you navigate the ever-changing waters of value-based payment initiatives. I'm going to leave this slide up for a little bit so you can contact any of us directly if you think of any questions later. And also don't forget to follow us on LinkedIn at the address below. Have a great rest of your day and enjoy the conference.
Thank you both so very much. We will see you all back here in about 15 minutes for our next session.